Hi everyone. So this is we talked about this a couple of weeks ago. So this is basically me giving you sort of the top tips or the top points from the 2021 ESC cardiac pacing guidelines. So I've picked out various bits of what's new and which bits of it I think are fairly controversial. So this may be a slightly skewed view, but hopefully it'll create a fair bit of chat at the end. Towards the end of the talk, I get onto aspects of surgical skills. So I'll probably skip through those slides fairly quick because it will overlap with the talk I gave a few weeks ago. So there's my conflicts. So in the next 45 minutes or so, 50 minutes, I'm going to basically try and cover what is in 94 pages of guidelines. There's 850 odd references. There's 16 key sections in the guidelines, but this is the first European update we've had for 8 years. Although the ESC brought out syncope guidelines in 2018, and there's quite a big overlap with the pacing guidelines and the syncope guidelines, which you would kind of expect. So I'm going to concentrate on what's new. This is a talk I gave to the Heart Rhythm Congress. I've also given it in-house at the hospital I work, so it's probably slightly biased towards UK practice. So I've picked out bits that are relevant. Hopefully there's probably quite a lot of it that is relevant for everyone on the call. There may be one or two areas not quite so. What I'm specifically not going to cover, I'm not going to talk about cardiac MRI scan and cardiac devices. That's a talk in its own right, and the separate guidelines on that. Myself and a couple of colleagues have published national guidelines on management of devices for patients undergoing non-cardiac surgery, and we're about to publish, we hope, it's taken about 2 years to write them, new guidelines on devices in patients having radiotherapy. So I'm not going to cover any of that lot, but I am going to look a bit on CAVI, conduction system pacing, a little bit on complications, and one or two other things. So it's probably the 10 take-home messages from the guidelines we'll go over. Some of this you may think is straightforward. You may do this already, but this caused quite a lot of angst when I presented it in our hospital. Our imaging team do not think that every patient should have their LV function assessed before they're paced. So if they have no symptoms of heart failure, one of our echo leads doesn't see the point of doing echoes. All of the device implanters categorically disagree with him. And we insist that everybody has an assessment of their LV function before they're paced. In people who present at a younger age, I don't know if somebody's got their mic on. I'm getting a bucket load of feedback. I mean, if you've got your mics on, can you just mute them for a second?
Dr. Gaddafi, I think you might be unmuted if you don't mind.
For patients who are younger, just because of the etiology, certainly in the UK, the etiologies are slightly different. There's some recommendations, albeit only a class 2A recommendation, for doing more detailed imaging studies, looking into potential causes of early conduction disease. And then if under 50, that's the point we would refer people through for genetic testing. And that vast bulk of people in the UK who get paced are over 70, 75. So patients presenting, particularly with AV block before the age of 50, ring some alarm bells that something else may be going. So we'd send those patients off for genetics, and I've certainly got a handful of patients with laminopathies that I've picked up by doing that. Initial assessment, very, very simple, and we've got some projects that we're trying to roll out, certainly in Ghana. So if anybody on the call is interested, we can talk about them a little bit later around how best to screen. So it's history, examination, ECG. You do not need a 12-lead ECG to diagnose complete heart block. You just need a rhythm strip. There's lots of patches, Holter monitors out there. We've been trying, and we had a project set up in Ghana to go just before COVID arrived, of using a live course. The only issue with the live core in Africa is that in Africa you don't have a license, so the devices need to be set up in Europe or the States and taken out to Africa. But having an alive core would be a perfect way to go and screen people, either in cardiology clinics or out in the community clinics, to try and find patients who've got heart block. And certainly our protocol was very simple. It was feel the pulse. If the heart rate was 40 or less, do an alive core and see what we can find. And then image with, for most people, they'll have access to simple transthoracic echo. Why does it matter? So some of you will be implanting CRT. Some of you are just starting off on your journey doing bradycardia pacing. I know from the WhatsApp chat over the weekend, some of you are doing conduction system pacing. If you're going to do a procedure on the patient, you want to do the right procedure first time. If you end up, this is the Replace registry, which is a big study out of America. But if you end up doing upgrades or revision or adding extra leads, your complication rate rises significantly. You do not want to put a device in and then have to change that device for a more complex device. If it can be avoided, there's clearly huge cost implications with the difference between CRT devices and dual chamber pacemakers, but there's the big risk of infection. Early re-intervention is the biggest risk factor for a device infection, which is an absolute disaster. So you want to be putting the right device in the right patient first time around, and you can only do that, in my opinion, if you know what their LV function is at the time of implant. We touched a little bit on the PADIT trial in the last talk. So PADIT is a trial which had, or the aim of the trial was twofold. One was to look at various antibiotic regimes to see if there was any difference in device infections. But as part of the PADIT trial, they developed a scoring system to predict device infection, which has since been validated. So this was a big trial of almost 20,000 plus patients. PADIT is an acronym. Each letter scores, so prior procedure, age, young being a higher risk cohort than elderly people for infection, depressed renal function, immunocompromised, and type of procedure. You score points, but you can see a device revision or upgrade is the procedure that scores the highest number of points. If you're PADIT 6, 7 or higher, you are deemed very high risk for infection, with almost a 3.5% risk of infection per procedure. So putting in a bradycardia dual chamber system to then need to put an LV lead in is bad. So revisions are to be avoided. Genetics, I don't know how much access you have on the call to genetics in the UK. The whole process of getting cardiac genetics is up in the air at the moment. There's lots of changes going on. At some point, it will become the sole responsibility of a cardiologist rather than the genetics team. At present, in the northeast of England, we have a cardiac geneticist, and we refer to him if we're concerned. But as I said, premature AV block in people under 50 should ring alarm bells that something funny potentially could be going on. And as I say, we'll often screen for various conditions, although laminopathy is one of the ones we see a reasonable amount of, and that we put in a lot of complex devices. So you're seeing people with conduction delay and dilated cardiomyopathy. So in terms of our guidance, 50 or under, refer to genetics. If they're over 50, that would not be an automatic referral, albeit in the guidelines, the strength of evidence for genetic testing in these people is relatively weak, level of evidence C. Now, sleep apnea, moving on, has got a lot of attention, and the device companies, certainly Boston, for a lot of years have been marketing their devices that they will detect sleep apnea in their patients. So Boston have gone down the sleep apnea route in a big way, although predominantly in their heart failure patients. In the guidelines, there's a lot of attention and discussion around screening people for sleep apnea, and that we know hypoxia increases your vagal tone. Therefore, particularly in people who use nocturnal AV block, the guidelines strongly recommend they give a class 1 indication for screening for sleep apnea before you proceed with pacing. We'll touch on some of the studies they've used to make that recommendation, and I'll leave it to yourselves to decide whether or not you agree with it. There's various questionnaires you can use to screen for sleep apnea. Stop bang is one of the common ones. If you look at my cardiology clinic, if I ask most of the patients, a lot of them have got BMIs over 35, most are over 50. They all have neck collar sizes of 16, 17 inches. We see quite a lot of males, a lot of people with hypertension, a lot of people who are tired. So there's an awful lot of patients coming through the general cardiology clinic who, using this stop bang questionnaire, may have sleep apnea, and we certainly diagnose a lot of sleep apnea in the clinic. This is a relatively small study, but this is a study where they put loop recorders in people with sleep apnea, treated their sleep apnea, and then looked what happened to their arrhythmias. And there is no doubt if you treat sleep apnea, people have less AV block. This was a relatively short study over an 8-week period. The trouble is, and the trouble for the recommendation for sleep apnea in the guidelines when you actually go to the references. So this study with the loop recorders had 23 patients. Then you look at all the other studies they have referenced to give it a class 1 recommendation, and they are all woefully underpowered to say anything. So the biggest study had 29 patients in it. So even when you put them all together, you've got a totality of around 100 patients. So certainly, whilst we may look for sleep apnea, I can't remember a case where I've not gone on and paced somebody. If I've seen certainly nocturnal AV block, sinus node disease different, but for nocturnal AV block. Syncope and bifascicular block. So there's two schools of thought with bifascicular block, and by bifascicular block, what they mean or what they've defined it as is either left bundle branch block or a combination of right bundle branch block and left anterior posterior fascicular block. So the syncope guidelines and a lot of the writing committee for the ESC guidelines, the authors come from Germany. Germany is privately funded, a lot of their practice, and you will see certainly in the syncope guidelines, a lot of their flow charts for the investigation of syncope will end with an EP study, which is very different certainly to UK practice. I've never worked in the States, so couldn't comment there. So syncope and bifascicular block, they say that EP studies should be considered when syncope remains unexplained after non-invasive evaluation. They then give a few parameters on what they deem to be an abnormal EP study. So if you've got a prolonged HV interval, or clearly have evidence of block. They do make the point that elderly and frail patients, it would not be unreasonable just to go straight to empiric permanent pacemaker. And for years now, there's often a debate in somebody who comes in with a fall in bifascicular block. Should they have a pacemaker? Should they have a loop recorder? Should you do anything? Patients with alternating bundle branch block should be paced. I think most people would agree with that. So looking at the ESC guidelines on bifascicular block, and again, this comes back to the issue at the start around imaging. If you've come in with syncope with bifascicular block, their first test is an echo. If your echo shows that you've got severe LV impairment, then you're down the arm of a complex device, be that an ICD or a CRT device. If your ventricle is not severely impaired, if you're elderly and frail, you can go straight down to pacemaker. If you're not, that's when it gets slightly more complicated and where they start to recommend EP studies or carotid sinus massage. And if you're still unsure, that's where loop recorders fit in. And again, I know we've certainly sent some loop recorders out with Pace for Life. So I know that some centres do have access to loops. That all said, this is a study that's come out since the guidelines. So some of the slides will, whilst we talk about the guidelines, which came out in 2021, we'll have evidence that has appeared since. So this is a trial called Sprightly, which was published in 2022. So this came out a year or so after the guidelines were produced. This is a study we took part in Middlesbrough. So you basically took patients who came in with undiagnosed syncope. They had to be over 50 and they had bifascicular block, and you then randomized them between a ILR or a pacemaker. And then basically fairly simple study, you just followed up and saw what happened to them. The bottom line, and the author of this study was at Heart Rhythm Congress last year, where he was giving a talk on updates in syncope over the last few years. Everybody who got a loop recorder ended up with a pacemaker by the end of the study. So the message was, if somebody has bifascicular block and syncope, just go straight to pacemaker, don't do anything else. There are a few little quirks of the study. Firstly, it's not particularly big. So there's 113 odd patients in it. Follow-up was for a couple of years. The thing that is slightly odd, some patients were deemed not to be suitable for devices. Some patients had dementia, some patients died, but all of the patients who would have been suitable for a device, as I said, crossed over and ended up with a pacemaker by the end of it. If you put loop recorders in people with bifascicular block and look at their rhythm, quite a lot of them have high-grade AV block. A lot of them had complete heart block. So 18 patients had complete heart block, either with syncope or pre-syncope. 6 were asymptomatic. So a lot of these patients will go on and develop high-grade AV block. The thing that was interesting, and I'm not sure if it's on this slide, was the one outcome it made no difference to was actually syncope. So you're treating people with AV block. It's a trial about syncope, but there seemed to be no difference regarding syncope recurrence rates at the end of it, which I can't explain. So in terms of syncope, moving away from bifascicular block, as a cardiologist, you see people with syncope and you go through various pathways. I'm worried, as you probably are, about those that have got unexplained and a high risk of sudden cardiac death. These are the patients we think about for ICD therapies. You've got those with structural problems. We're a big TAVI unit. Our TAVI team keep us very busy with pacing. So if you're intervening, if you've got a surgical unit, if you're doing valve surgery, you will pace. We see lots of arrhythmias. But then you've got the group who've got reflex or orthostatic intolerance, and there is an awful lot of those patients. So the syncope guidelines say when it comes to cardiac pacing in patients with reflex syncope, and this is a hugely controversial area, it needs to be severe, it needs to be recurrent, unpredictable syncope. So if a patient is young, you typically would not pace them. This is a group of various individuals. A couple of these are from our unit. There is a trial in the UK looking at Micra for the treatment of vasovagal syncope in young people. The argument being you can put the device in. Leadless pacemakers have lower complication rates than transvenous systems. Infection rates are lower. These patients often grow out of their symptoms, and it may buy them time and improve their quality of life. But this is a fairly controversial area. So young patients in general, pacing is not indicated. Then there's a whole load of things you cannot do. So our protocol in our blackout clinic is the first time we see them, they get lots of lifestyle advice, and we don't do much else in the way of tests. If despite all the lifestyle advice, they come back with recurrent episodes, we then investigate further. You can do carotid sinus massage, tilt table testing. There's ways and means of doing it. The diagram on the bottom right is a setup they have in Newcastle, which is just up the road from ourselves in Middlesbrough, which is negative pressure. It basically sucks all the blood out of your body into your legs to make you black out. How reach or true that is to real life and how reproducible that is to what the patients get when they're out and about. But for some occupational reasons, you need to do it. But it goes through various things at which point you may consider a pacemaker. I think if you look at pacing rates for any big centre, very, very few patients get paced for reflex syncope. There may be the odd one, but it's small numbers. So for reflex syncope, what they recommend is dual chamber pacemaking is indicated if the patient has recurrent syncope, if they are not young, so if they're over 40, and it's severe, unpredictable. If the patients get warnings and they know what brings it on, do not pace them. This bit is the contentious bit. So a pause, symptomatic pause of 3 seconds, asymptomatic pauses of greater than 6 seconds, cardioinhibitory carotid sinus syndrome. This got a lot of debate when we presented this locally with lots of different views on what the right answer is. Congenital heart block, we see from time to time in the UK. Not all patients with congenital heart block will need a pacemaker, particularly if they're asymptomatic. The ESC come up with a set or a list of criteria where pacing may be considered. So if your mean heart rate is less than 50, talks about pauses, escape rhythms, QT intervals, ectopy, etc. Clearly, if the patient's symptomatic from it, that is slightly different to the asymptomatic patients. Then there is a debate how many leads you would put in a patient with congenital complete heart block. So the patients have got congenital heart block. These patients do not get pacemaker syndrome, in my opinion. So if their ventricle is good, then a VVIR pacemaker should be enough. Some people think they should all get dual chamber pacemakers to restore AV synchrony, and others will use block HF, and we'll touch on block HF in a second, because they will be paced the majority of the time and say all of these patients should get CRT devices. Basic rule of doing anything to a patient is keep it as simple as you can to keep the complications as low as possible. Moving on to the CRT guidelines, there's a few things about the CRT guidelines people need to be aware of. So CRT is recommended in patients with an indication for pacing, a high degree AV block, and an ejection fraction less than 40%. So the standard CRT guidelines would say an ejection fraction less than 35%, because that is severe LV impairment. Block HF, which is the only study that is published in paper form. Other studies are out in abstract form only, but Block HF had an ejection fraction cut off of 50%. So where the ESC get 40% from, nobody knows. They then talk about that CRT should be considered for patients with heart failure and severe LV impairment. if they are in AF and a QRS of greater than 130 milliseconds. The key CRT trials used 130 as a cutoff. Some of the earlier studies used 120 as a cutoff. You will not get effective cardiac resynchronization therapy if you're putting devices in people with QRSs of 120. They also say that if you're going to be using CRT in patients with AF, you do need a high CRT pacing percentage, and you should have a low threshold for AV junction ablation or AV node ablation. And there are various studies looking at this at the moment. There are studies randomizing patients between AV node ablation, AF ablation. So there's going to be quite a lot come out in the next 3 or 4 years around AF and CRT. The APAF CRT trial came out in 2021. This was a study looking at doing upfront AV node ablations on people getting CRT. It's interesting because when you look at the study, there are some fairly significant methodological flaws in it, yet it has been hailed as one of the landmark studies of the last decade. I am slightly suspicious some of that might be down to the authorship of who is on the paper. But APAF CRT, to be hailed as one of the best studies ever, only had 133 people in it. They've done a lot of extrapolating of the data, and they've turned round and made the conclusion at the end of the trial. So this is a trial of people with permanent AF, narrow QRSs, who get CRT and an AV node ablation up front versus rate control with drugs, that you have a number needed to treat of less than, or in essence, 4 for mortality benefit. And I don't think that statistically stacks up when you've only got 133 patients. But the lead author is very well known. It would be nice to see this trial on a much bigger scale and see if the results are replicated. So moving on, and I'm going to touch on block HF because I think people need to be aware of block HF because it gets talked about an awful lot. But there are some issues with block HF that you need to be aware of. So this is a summary table looking at the evidence of randomized trials of de novo CRT implant compared to RV pacing in patients who've got a standard pace anti-bradycardia pacing indication. So these are people who are going to be paced who do not have severe LV impairment. So hobby pace and combat, you can find the results, but block HF is the main trial, and you can see by the number of patients in it, it's significantly bigger than the other two. So block HF is interesting because it asks a very relevant question of, if you're going to pace people who are likely to pace a lot, who have impaired LV function already, would putting a CRT in those patients be better for them than just dual chamber pacing? So they wanted a group of patients that would pace a lot, so they looked at people with AV block. So you would have thought it is quite easy to find a lot of people with AV block, and quite a lot of those people will have ejection fractions of under 50%. When you look at the algorithm of the trial, 690 people were randomized. So they were split 50-50 into the respective arms. But on average, there was, for argument's sake, there's 350 in each arm. Quite a lot of patients withdrew or were lost to follow-up. Now, this was a Medtronic-sponsored trial, So most industry-sponsored trials are fairly rigorous, and losing people to follow-up doesn't happen on a regular basis. There was quite a few people that died, and then there was an awful lot of people that crossed over. So this was invested at the discretion of the individual cardiologist. So then when you look at those that were there for analysis, the key question the trial was trying to answer was, would CRT stop people's ventricles from becoming more impaired with high percentage pacing? A huge number of patients had echo data that was missing, which meant they could not analyze for the primary endpoint properly. So the whole conduct of the trial and the amount of data that was lost is a significant worry. You had 918 patients initially approached, of which 691 were randomized. There's a whole smattering of reasons. Some people didn't meet the inclusion criteria, which is fair enough. Some withdrew consent. They then removed those that had unsuccessful implants. So if you're going to do a study like this, it's got to be on intention to treat. But they kicked a load out because they couldn't get the LV leads in. And then some went in but weren't randomized properly. So the whole trial conduct isn't good. And the trial was conducted in 60 big centers in America and Canada. So I've got a fair amount of cynicism around block HF, because I think for a research trial, there were big questions to ask about the team and how it was conducted. The other thing that comes out is when you look at the adverse events. So there was a massive crossover from RV to BiV pacing. So a lot of patients got upgrade procedures. We know that comes with high risks, but even in the standard arm, you've got high complication rates for people who were randomized to RV only pacing. So you've got complication rates of almost 1 in 5. So whilst people use block HF as an argument to put in CRT, you just need everyone just needs to be aware of the trial and some of the limitations, because I think the question it asked was a good question. Now, the other thing with block HF, and this may not be relevant, or you may not be aware too much of this. So this slide is a slide from a trial looking at dapagliflozin. This is dapagliflozin in people with heart failure with preserved ejection fraction. Well, dapagliflozin, there's a lot of attention about it in the UK at the moment. It's currently going through the process to be approved by NICE. NICE's provisional statement is they are not going to approve it. The companies have appealed, and we'll find out in a few months' time what the answer is. But the trial was positive on a composite endpoint of cardiovascular death or worsening heart failure. When you look at the individual endpoints, it was not positive for mortality, which is where all the debate around DAPA in heart failure with preserved ejection fraction is. If you look at block HF, likewise, there is absolutely no mortality benefit at all. The only benefit is hospitalization for heart failure, which is a relatively soft endpoint. So for a therapy that is significantly more expensive than a bradycardia pacemaker, with significantly higher complication rates, the only thing you're achieving is a slight reduction in hospitalization for heart failure. You're certainly not improving mortality. So that's enough of me going on about block HF. The next area the guidelines touch on, and the research base in this area is evolving rapidly, so that, the guidelines are 2 years old, came out in 21. there's been a huge amount of data in the literature around conduction system pacing between the guidelines being produced and where we are today. So the concept of conduction system pacing is not new. So we started by putting the right ventricular lead in the apex. Then there was decades of research looking at right ventricular septal pacing. We've then had a lot of research looking at His bundle pacing, and the current area of interest is predominantly around left area bundle branch pacing. So as a scientific question and sort of research question, there's a lot about this we don't know. So conduction system pacing at face value, you would think would be very good and patients would do very well with it. The people who were talking about His pacing, so 3 or 4 years ago, you go to the meetings and there'd be the same 2 or 3 people always talking about His system pacing. They are now very much talking about left bundle branch pacing and have moved away from His pacing because, firstly, it is difficult to do properly. Secondly, it's got very high complication rates. And thirdly, following the devices up is can be very challenging. At present, they say that His pacing is only recommended in the case of unsuccessful coronary sinus lead implantation, so with a failed CRT. There are no solid, good, robust, multi-center randomized controlled trials. There's lots of single-center observational data, but when you look at a lot of the literature, it's from the same study group. And if a group gets good at something, they will publish their results, whether or not that is reproducible. So conduction system pacing at present, certainly in the UK, NICE say it should be only done as part of a research trial. We know some hospitals do nothing but conduction system pacing. There is a British Heart Foundation multi-center trial called Protect HF, which is looking to answer this question once and for all. And I personally think we need the results of that trial before we switch, because standard bradycardia pacing has been around for a very long time and has saved many, many lives. It's relatively simple to do with low complications. These more complex ways of pacing are technically more challenging and come with higher complication rates and some significant complication rates. The guidelines also touch on septal pacing, because as mentioned, there was a vogue for septal pacing for many, many years. There was a trial called Protect PACE that was published probably 8 or 9 years ago that showed septal pacing has no benefit over apical pacing. The only caveat may be if you've got an elderly, frail patient where you do not want a lead right down at the apex. So this is this has come out this year. This is basically a European Heart Rhythm Association survey asking operators where they feel conduction system pacing will fit in. So which patients are more likely, would they be more likely to offer conduction system pacing to than not? So AV block with narrow QRS and failed CRT, pace and ablate are the 3 big areas where people feel it may have a role going forward. Then people asked about conduction system pacing, what their preference was between His pacing and left bundle pacing. And you can see on the chart, the dark green on the right is much more prominent than the green on the left, which largely reflects the fact that left area bundle pacing is easier to do than His pacing and is more forgiving. But I imagine with time, the left bundle will be the technique that gets the foothold in the market. One of the problems at the moment is operators clearly do not have confidence in doing it. So quite a lot of operators will still put in a backup right ventricular lead, particularly this is predominantly for his pacing. But almost 50% of patients are ending up with an RV apical or septal lead put in because they're worried about their his lead. So in terms of where it may have a role in AV block and ejection fractions over 35–40%. Certainly at the moment, NICE, which for ourselves in England, the people that opine are looking at this and are coming out saying it really should only be used in the context of research trials. It should not be a standard go-to upfront procedure. That is my view on it, but I do know that there are centres who've gone over to conduction system pacing as their default strategy for pretty much everyone. Now, one of the problems you've got, so we've had 2 decades, as I say, of research of looking at putting leads in places other than the right ventricular apex. And everybody said RV septal pacing makes perfect sense. People will do better for it. We should do it. But there is a challenge of putting the RV lead in the septum. And there was a paper on one of the WhatsApp groups about how you know you are in the septum as opposed to being in the RV free wall. And it talks about using multiple different fluoroscopic views. We drill into our trainees. You cannot put a septal lead in PA. You have to be in LAO, and you have to have a steep LAO to make sure that it is pointing towards the septum and away from the free wall. This is a patient I was involved with. Who had a pacemaker put in one of our local centres nearby. Those of you that are switched on will realize there's a wire in this patient's pericardium. This was us draining their draining their effusion when they're presented with tamponade. So this is the view in PA, and the operator who put this lead in only ever screens in PA, we are told. This was the view in LAO of the same system, and it is very clear in LAO that that RV lead is nowhere near the septum, and it's gone straight through the RV free wall. In the Protect PACE study, there was a part of the protocol of implanting the leads. You had to do various things to do everything you can to make sure the lead was in the right ventricle, was in the RV septum. As part of the trial, they then did CT scans on a select number of patients, and even doing all the steps that was mandated in the protocol, quite a lot of the so-called septal leads were in the free wall. That clearly has some implications if you're doing left bundle pacing, where you are putting leads through the septum, of making sure you are definitely on the septum. Otherwise, your rate of tamponade is going to increase. TAVI, I will touch on very, very briefly because it may not be relevant for those of you out who are not working in TAVI centres. TAVI pacing rates will vary depending on which valve you put in. There's lower rates with the Sapien valve. The other self-expandable valves have higher rates. TAVI pacing rates will vary from 10 to 20%. There's a lot of chat about what you do with people with conduction abnormalities after TAVI. So if you've in heart block, you've got alternating bundle branch block, it's relatively simple. We know that right bundle branch block is a risk factor. At the start of our TAVI program, we empirically paced people with right bundle. We've stopped doing that, and the guidelines have come out and say the same, that prophylactically pacing patients with right bundle branch block pre-TAVI isn't indicated. They then have some algorithms on what happens if your QRS or your PR interval alters following the procedure on whether or not you do an EP study or do ambulatory monitoring. I think anyone who works in a TAVI centre will have paced patients post-discharge who come back in with high-grade AV block and ventricular standstill. New left bundle post-TAVI is what people worry about. It depends on the type of valve you're putting in, but looking at the studies can range from anywhere from 13 up to almost 40%. The concern is that that is a surrogate for the development of more high-grade AV block in time. However, the MAR trial is relatively large, but their 1-year sudden death rate was very low. They do say that in some patients, so signals that indicate, so patients with AF or prolonged PR interval could be at higher risk, and that these patients potentially should be kept in hospital longer. There's a huge drive with the TAVI programs to get people in and out of hospital as quick as you can, and we certainly do day case TAVI. And those that are kept in will often be home the following day, but for some they're saying they should be kept in for at least 5 days of monitoring afterwards. So this study had 103 people with new onset left bundle branch block. They put loop recorders in them, and then they followed them up for a year to see what happened. 20% of patients had bradycardia. Half of those patients ended up being paced. Doesn't necessarily mean they all had symptoms. Most of the events that they saw on the loop recorders occurred early. And again, if you're pacing people after TAVI and after aortic valve surgery, whilst you pace them, or some of them before they go home, quite a few of them, if you look at 3 months and 6 months down the line, no longer need their system, and conductions can recover, which probably fits in with this. The table on the right is just looking at a whole host of other studies looking at the same thing with the new left bundle branch block post-TAVI and what the pacing rates are. So ranging anywhere between 7 and 17%. But TAVI patients come with a warning of a lot of them will end up needing something doing. This is a meta-analysis that came out this year in Heart Rhythm, looking at what the role of EP studies are. So in the guidelines, they make reference to considering EP studies in these patients. Bottom line is EP studies don't help you at all. The only one that might is having a HV interval greater than 70 milliseconds before TAVI. That is abnormal anyway. But certainly doing routine EP studies is something we do not do. And I don't think we've ever done an EP study on a patient post-TAVI to try and decide should they or shouldn't they get a pacemaker. I'm not sure if anywhere else does, but certainly it's not common practice in the Northeast. If you go on to PubMed and look at the clinical trials databases on and look at what's coming. So I accessed various things at the end of March, but there's 127 trials currently underway looking at pacing and TAVI. Conduct TAVI is a big Australian trial where people are trying to look at the role of EP studies and loop recorders to try and work out what's best, what to do with patients. The fact there's 127 ongoing research trials registered tells you that nobody really knows what the answer is yet. How long to wait? So for TAVI, we usually pace them reasonably early, but that is because they have a temporary wire in, and we're pacing them because we want the temporary wire out. Patients with acute infarct, we will often wait, and certainly there's somebody on my list tomorrow who was a late presenting inferior who's been sat waiting for the last 10 days or so, and I'll find out tomorrow whether or not they need a pacemaker or not. For surgery, there's an arbitrary 5-day. There's no evidence base for this at all. This is consensus opinion, but most units would wait at least 5 days before committing a patient to pacing who's had cardiac surgery. usually with cardiac surgery patients, you've got the benefit that they've got epicardial wires in. So you've got the luxury that you can afford to wait a bit longer and they are safe. Leadless pacemakers, I'll wrap up shortly. Leadless pacemakers are great. They have lots of benefits, but they are incredibly expensive. So a VVIR pacemaker will cost about £700, £800, so $1,000. A leadless pacemaker in the UK costs £7,000. So whilst leadless pacemakers are used, they are very expensive. In America, where you've got an insurance-driven market, over 40% of VVIR pacemakers are now leadless. So the European guidance reflect that to a certain degree, and that they will specify that it is reasonable to use a leadless pacemaker where upper extremity venous access is a problem. So for myself, we work in a big renal unit. We have lots of dialysis patients. If patients have had a device infection, as it says, patients on hemodialysis, there is no doubt leadless pacemakers will become the future once cost starts to come down. The implant times are quick. They work well as VVIR pacemakers. At present, however, the algorithms for dual chamber pacing still need some refinement. There is also no randomized trial looking at leadless pacing versus single chamber transvenous pacing. So the leadless trials have all come out saying we can do it, but there's not been a formal randomized trial between the two yet. This is a big registry from America. This is from Medicare insurance, looking at complications. So there is real world data out there, and there is no doubt the message coming from this and others is that chronic complications are lower with the leadless devices. But as I say, they've really taken off in the States, with over 40% of the market for VVI devices now being leadless. Infection, we touched on this last time, so I'm going to whiz through this. We've gone over all of this before. In terms of access sites, the guidelines do actually stipulate that you should preferentially try and get access via the cephalic or axillary approach rather than going to the subclavian. This is largely around complications of pneumothorax or subclavian crush. There is no doubt cephalic access in terms of hand skills is a different skill set to subclavian access. A word of caution, you can still cause a pneumothorax going via the cephalic. So this is a patient of mine who had a dual chamber ICD put in many years ago, and I completely missed their right-sided pneumothorax caused by the atrial screw because I wasn't looking at the right lung. This patient came back in and had about 1 litre of blood drained out of his right lung, and the active fix mechanism of the atrial lead had caught the right lung. I've had that happen to me twice. So just beware that if you do go cephalic, you still can get a pneumothorax or a hemopneumothorax, but it's often on the other side. Remote monitoring, I'm going to skip, and I'm going to stop there and open things up for questions.
Fantastic. Thank you very much, Dr. Turley, for this, for all of that. Do we have any specific questions from the group at all? I posted some things in the chat that were relevant to what you were talking about.
I'm just getting those up there, Jay, to have a look.
Yeah. So if you have any questions from the group, please, shout out or post in the chat. We're happy to read it out loud for you. So I did, when you mentioned the Sprightly trial, one consideration for that, obviously loop recorder access is relatively limited right now. Yeah. Across different programs. So we would definitely recommend using that trial as a reference point. Do you have any thoughts on that, Dr. Turley?
Oh, sorry, I was reading all the questions, AJ. Sorry, what was that about? Was that Sprightly?
Sprightly, yeah, like the consideration of using loop recorders when you have limited access or resources to them.
I mean, the trouble, I don't know how much loop recorders cost in the States. Loop recorders in England are the same price as a pacemaker, if not more expensive.
Yeah, correct. Same.
So they're about £2,000 for Medtronic links, so just under. Certainly, our preference is we just go straight to pacing. So if we've got somebody in, and we had somebody last week where one of the non-pacing cardiologists was agonizing for hours. Should they get a loop recorder? Should they get a pacemaker? I would just put a pacemaker in. And there's a lot of patients over the years I've seen who've had loop recorders put in who get pacemakers very quickly. And it's just a waste of it. You're just wasting money, particularly when you haven't got ready access to the loop recorders. I would, if you do have access to loop recorders, I'd use them for people with unexplained syncope whose ECGs are otherwise normal, not people with bifascicular block. I think Sprightly is actually quite an important trial with a fairly clear message.
Yeah, perfect. I appreciate your insight. So yeah, prioritizing loop recorders to rehash that. Prioritizing loop recorders for unexplained syncope.
Yeah.
So you mentioned CSP, so conduction system pacing. Do you have any insights as far as like how we're going to deal with chronic retrieval? Just because I think that, you know, it's getting popular in the US for sure, and I think it will make its way all the other programs.
Worry. So when I started CRT implants, which was quite a long time ago, we used to put a lot of Starfix leads in. So Starfix leads were Medtronic unipolar active fixation leads. They do not come out. So we've had some horrendous extraction cases, and when we don't do extraction anymore, but when we did them with a cardiac surgeon scrubbed with us as standard. And Starfix leads do not come out. I am slightly worried what will happen with conduction system pacing leads and how easy they will be to come out. I think we might be causing problems. We went through a phase when CRT, in the early days of CRT, had quite a high failure rate. We then went through a phase of putting epicardial leads in. And then there was a phase, I don't know if it took off in the States at all, but there was a phase of putting transeptal LV leads in. So you do a transeptal puncture, snare active fix lead. So we'd use a select secure lead, which is often the leads that they're using for conduction system pacing, and basically grab it, take it from the right atrium into the left atrium, go across the mitral valve, and then anchor it into the lateral wall of the LV. And there are certainly case reports of those leads getting stuck to the mitral valve and not coming out. I just think all these techniques that are getting more complex, we will be storing more problems for ourselves. Even a transvenous lead can be quite difficult to extract. And that's when you've got just the helix of the active fix in the myocardium, not the body of the lead. So I think it will keep those centers that do lots of extractions busy.
Yeah, that's a good point. Perfect. I appreciate your input on that. One thing, so you mentioned, you know, septal placement using LAO view. I went ahead and posted an article. There's many of them out there though about individualized LAO. So in this article, they talk about using EKG to pre-assess. You can also do RV grams, things like that, but just ensuring you're going LAO enough. I find that in some centers we just stick to AP and RAO, and we're not really seeing our septal orientation at all. And sometimes 30 is not enough. A lot of times 40 isn't even. So
yeah, no, I completely agree with that.
Awesome. And then yeah, that was all the stuff that I had. Was there anything else from the group? I don't see anything from the chat yet, but we'd love to hear your input. All right. Well, I appreciate it, Dr.
Okay,
Turley. Oh, yes, sir. Dr. Dr.
yeah, AJ. Yeah, thank you very much, Dr. Andrew, for the great presentation.
That's all right. Glad you enjoyed it.
Yes, sir, very well. I have some few clarifications. One, a few days ago, there was this pacemaker that was shared in the cardiac devices group from Fortis. It was shared by Dr. Panna Jaswa. Panna used, I trained on that too when I was in India. So I want to know, because what she did there was LBB pacing for a 38-year-old a 38-year-old man who had surgical repair of the aortic valve. After 8 days post-repair, this guy came with, I think, what looks like, I don't know, what looks like intermittent heart block.
Okay.
What looks like a heart block. Yeah. And with widening of the QRS complex. And after the pacing, she showed the ECG after the post-pacing, and it became fantastically narrow QRS complex. So now, what I want to know is what is the rate of lead dislodgement when you hook that lead to the when you hook the lead to the left bundle? Because even when the ROV pacing, yeah, correct. So this is before the pacing, and after, yeah, this is before the pacing. The next one is after the pacing. So what is the rate of dislodgement of these leads? Then two, the second question is that these leads that we are using for the left bundle pacings are all active leads. Is there any role of a passive lead in this area of new development in pacing?
So the second question's easy, no, because you need to go through the septum to get to the left bundle. So the only passive type system which is really niche, there's a system called EBR, which is a leadless
EBR.
EBR, yeah, it's a leadless ultrasonic system for LV pacing.
Okay.
Where you're inside the left ventricle, so you potentially could stick that anywhere you wanted in the left ventricle, which doesn't have a active fix in the sense of a screw on the end of it, but it has 3 metal tines. So once it's deployed, you can't move it. But coming from the right side over, you're going to need something that will go through the septum. So you're going to need something with it. You're going to need an active fixed lead. I don't think there'll be any. I can't see how a passive fixed lead would get you to the point where you want to pace. And I think if you've got a passive fixed lead, the mechanism on the end of them, they're the worst leads to extract already. Active fixed leads are much easier to extract than passive fix. Dislodgement rates, I don't know the answer because we don't do conduction system pacing. We're just about to start. Myself and one of my colleagues are going down to London to get enrolled in the British Heart Foundation trial. So we're going to start in the next couple of months. So we don't do it. Certainly for the HIS pacing, there's a very steep learning curve and there's a lot of complication rate at the start. And even in experienced hands, 50% of people are still putting in a backup RV lead. I don't know if anybody else who does it off the edge has done it as to what the complication rates are. That's the EBR device. But the
great.
The EBR device is incredibly niche.
Yeah, here's the device I believe you're speaking about, correct?
Yeah. I mean, it's getting presented at HRS as a late breaker in a few weeks' time.
Is that the one that's powered by, like it doesn't have its own battery? It's like ultrasound or something?
Yeah. Yeah, I mean, basically EBR at the moment is for failed CRT.
Okay.
But it does, there are certain features. We've implanted a lot of these EBR devices. There are certain features of the system that at face value lend itself to left bundle pacing.
Okay. So my second question, thank you very much, sir. My second question is, can you throw some light on the issue of left ventricular lead placement in CRT?
That's probably
because the CRT, the volume of CRT in Nigeria is increasing.
I can give you a talk on that if you want. That's probably a talk in its own right, because it's
good. So if we can take it a talk of its own, then
yeah.
we bear out our concerns and our questions, so that we'll be able to understand deeper what actually we need to do. Because the rate of failure is, the rate of CRT is low in the country currently, but that doesn't mean that there are no CRTs that, that every CRT that we want to take is always successful. There are some where the rate is low, reason because of the much advancement and the catheters that you can use to take into the coronary sinus.
Yeah.
But locating the coronary sinus is not enough for a successful CRT. The key thing about the successful CRT is to identify the right placement of that lead. And if that right placement is not done, that patient will not have the optimal benefit that should be kept in mind while the procedure commences. So maybe we will take another discussion from you on it so that we can bear our mind on this issue, sir.
Yeah, no. Yeah, I'll have a chat with Julius and we can sort a whole session around CRT and optimizing outcome for CRT.
Yeah,
that's a whole talk in its own right.
I think Dr. as well was considering doing a presentation on CRT, so maybe we could do a combined chat. I can send you the I put together like slides on placement of LV leads. I'll send that to you, Dr. Turley.
Okay,
good.
I've got a few talks.
Good.
Yeah, I'll be able to sort that.
Yeah.
Oh, good.
Dr. So
I still have a question. I still have another question. And Dr. Andrew, do you think for patients, you share a slice on a cardio inhibitory syncope, and it was a trial that you did. Then my network was having an issue, so I didn't get the detail of what you discussed about that particular trial. Was it very successful? What was your conclusion on that cardio inhibitory? Because you are part of that clinical study.
Yeah, no. So the study I mentioned, there's a group in the UK that are looking at putting in micro leadless pacemakers in young people with cardio inhibitory syncope. So it is enrolling people at the moment. It's not finished. The paper, the paper that was presented was just a case series of 5 or 6 cases where people have used micra in young people with profound cardio inhibitory syncope, where patients haven't had a recurrence since. So the classic teaching is you never pace young people with cardio inhibitory syncope. But there's a group in Southampton who are leading the trial who are saying, with the advent of micro devices and the fact you can just leave it there, let it run out in 10 years' time, that actually it may be a niche area for leadless pacing, but we don't know the answers yet. So that trial is underway at the moment.
I think Dr. Oladimeji had a question?
Yeah, thank you so much for the presentation. Hope I'm audible, sir. So my question is about some patients that have congenital heart disease, in which they have probably VSD, tetralogy of Fallot, in which you can get access into their LV. So they have this congenital disease with a probably complete heart block or a high-grade AV block. And you know it's possible to get access to the LV. So there was this talk about giving them a bi-V pacing, but getting access through the defect into the LV. However, patients can now be continued on anticoagulants. So I just want to get your experience and your advice regarding this.
I mean, I don't work in a congenital unit. So our congenital heart disease unit is Newcastle at the Freeman. We, in small numbers, we have deliberately put leads. We have done transeptal punctures and put leads directly into the left ventricle. We've done that only 4 or 5 times, and everybody we've done it on has had an indication for lifelong anticoagulation, and have had a reason why they couldn't. They've either had failed CRT, or they've got some reason. We had somebody with Epstein's who flatly refused epicardial wires, but the surgeons very helpfully had stitched their mechanical tricuspid valve above the coronary sinus, so we couldn't access it. So it was the only option we had. It has a very high complication rate in terms of TIAs. So it certainly isn't without risk. EBR potentially is the answer for those groups. So that is a device that goes into the left ventricle, but it is very small with no wires, and it gets endothelialized very quickly. So patients don't need to be anticoagulated, but EBR at the moment is not commercially available. Time will tell in the next 5 years where it all ends up. But the EBR device may have some advantage, but it's got a problem with its battery doesn't last very long. So it needs to be, the ultrasound needs to be powered by an external battery, and the battery lasts about 3-4 years at the most. So they're working on the battery technology at the moment. So yeah, I have no knowledge of deliberately pacing people through a defect into the left ventricle in the congenital heart disease group, because we don't do it. But when we've deliberately done it for failed CRT, it's fairly miserable, and a lot of patients will have TIAs even if they're anticoagulated. Great. If nobody else has got any questions, I'm going to disappear because I've not had anything to eat yet. And I hope to catch up with you all again, and we'll have a chat. If you want to do CRT next time, we can have a chat about CRT and how to improve outcomes.
Thank you very much for your time, Dr. Turley. That was fantastic, and we really appreciate your insight to follow that.
Cheers, everyone.
Thanks, Dr. Turley. Thank you.
Be in chat with you.
Thank you very much.
Yeah, sure, definitely. Yeah.
Right. I'll see you later. Bye.
Thank
Later,
you.
bye.
Bye.
Thanks.
All right.
We can't hear you properly, AJ. Hello, AJ.
Oh.
Oh, you keep cutting out.
Okay. Well, how's it now? Can you hear it all?
It's still a bit not great.
Okay.
It's better now. Better.
Okay. I will try, and if the signal's so bad, then we can always just pick this up next week. But does anyone have an answer for this question here? What's happening in this EGM? Julius, can you hear me?
Yeah. Do you want me to have a crack?
Yeah, why don't you take a stab at it?
Well, I mean, the atrial EGM, I mean, it looks like I was thinking multifocal atrial tachy. That's been undersensed. But it's got VIP ventricular intrinsic preference piece in there. So I don't, and then it's like a piece in when it's actually undersensed when there's an atrial event signal there, and it's obviously ignored it and just gone ahead and paced the first A piece in, and there's nothing at all being seen. And then you got A sense there, and then you got V pacing. I don't know if it's the algorithm kicking in VIP, because that's obviously Abbott. And then you've got like a signal there, and is this overlooked it and A pacing? I can't see, so I don't know. What do you think?
Yeah,
So
no,
it's not mode switching when it should be.
correct, exactly. So it's basically just in a ventricular based timing here during these episodes. It's under sensing in the atrium. You're exactly right. You can see it has the gain written out right here. I don't know if you can see my cursor,
Yeah.
but the gain is here, and you can also see a visualization of the total gain. So you can see this tree, this interrogation thing is in the way, but you see the tree on the atrium here, and you can see how much the gain is. So this is the height of 1 millivolt. These signals are less than 1 millivolt. I'd say they're probably around 4 or 3. So the device is under sensing. I don't know what the sensitivity is set at on the device. We probably want to either lower the sensitivity to a fixed at 0.3, possibly lower, turn on auto sensing, or maybe just go ventricular VVI only pacing if we're not going to be if they're constantly in this atrial arrhythmia. One thing too to note here, that you see the V pace, how short this is. We don't actually know if we captured. This is why I always say you want to have a unipolar signal up, a unipolar EGM channel. This is a V sense amp, and as you can see, when you pace, the artifact is very small. In other cases, the artifact could be very large, and you could think you're capturing, but because we don't have a far field or unipolar tip to can vector, we can't actually see depolarization across the myocardium. So I would always recommend having unipolar or having an EKG up, just so you know you're actually capturing, because that can be problematic. So here's the answer. And by the way, I will post these in the group as well, but I'm just gonna hold it on the screen for a second so people can review it on YouTube and pause when necessary. Covered everything there. But yeah, so sensitivity needs to be increased, so make the device more sensitive, and you do that by actually decreasing the sensitivity value. So bringing it down to 0.3, 0.2, whatever you need to do so you're properly sensing. Okay, who wants to take a shot at this one here? What's going on?
I'll take one for the team.
Go for it.
My first impression was, well, I mean, if we break it down, we start with an AR there, which suggests that the atrial event is in a refractory period, and then you're followed by a paced event, which is then followed by a ventricular paced event. Sorry, I'm just losing that. So to me, at first, I thought this was probably, I'm not sure if anyone's heard a lot about this, is R&R VAS, which is a repetitive non-reentrant VA
Synchrony.
synchrony. That's the word I was after. And yeah, so that was my first kind of thought. So this is maybe, which means that every time you get a VP, that is then VA conducted, like almost like a PMT, but that AR is in the refractory period. And so that is then followed by a ventricular paced event, which actually doesn't capture the atrium, but it still sets off a paced AV delay, which gives time for the retrograde conduction to get its refractory back, and then hence you got this reentrant VA conduction going on. So yeah, I thought it might have been R&R VAS.
That's exactly correct. So yeah, R&R VAS, as you're saying, here we're pacing in the atrium. They count. So the way that St. Jude devices, Abbott devices work is we're counting every atrial event. So a pace and an AR are both counted. So when these are high enough to hit the filtered atrial rate, what's called FARI, it will cause the device to mode switch. So here SIR is your sensor indicated rate, which means the device is pacing based upon what the sensor reads. So it's pacing faster than the base rate. And then AMS means it's mode switched to a different rate. So you can see here with the sensor indicated rate, the reason we're having this R&R VAS is because one, you have a very long paced AV delay, and then the sensor indicated rate is putting us right up there. So we have a very small atrial alert or atrial alert window, which means that when we pace, the atrium is still in refractory. So here's the answer. So what's happening? Functional loss of capture due to R&R VAS. We have a very long PVARP, and we have to cover up that retrograde, which is proper because if we didn't have a long enough PVARP, we'd have PMT. But this can still obviously be symptomatic for a patient. They don't have AV synchrony. I've had patients we checked on the floor where they're going in and out of R&R VAS, and you can see they have an art line in, and their blood pressure is just plummeting every time it enters this. So they're losing 20 to 30% of their output every time it goes into this cycle. So ways to kind of avoid this is obviously shortening your paced AV delay or adjusting your sensor or your base rate to allow more time for that atrial pace to occur when the atrium is ready to receive a pace and react to it appropriately instead of being functional loss of capture. So dead on. Thank you very much on that. Any questions on this one before I slide on? All right. Here's the rest of it. I'll hold this for a second. So if someone needs to pause, and once again, I'll post this in the group. Oh, Elvis, I see you in the chat. T-wave oversensing. So that's actually that is a valid point. It could be T-wave oversensing. In this case, it is R&R VAS, but I think that is a good consideration to have. I would say you would just want to look to see if you're pacing the atrium and you're actually capturing the atrium. You will probably not have this kind of atrial event occurring in the T-wave then, because you won't have this retrograde. It won't be able to accept that retrograde event. So that's a good way to see if it's T-wave oversensing versus retrograde atrium.
And if AJ, if it was T-wave, because
Yes,
I was thinking that as well before, if it was T-wave oversensing, would you be able to say on the leadless EGM there, like, because if you say if you go back up,
did I cut out?
oh, yeah, slightly, like, a little bit. So like, I was thinking that as well, and I looked at the little notch on the leaders one, which is obviously close to your surface ECG. So if it was T-wave oversensing, like, because you can actually see notches on there. So so I ruled the T-wave oversensing out, because you can see the notch on if you like the surface ECG, the leaders ECG. Do you get my point?
Yeah. So could the leadless?
Because you can't see the remaining half of the strip. You can't see the notch on them, but you can see a notch on here, which looks more likely retrograde, because it's showing up, the signal showing up on the surface ECG, whereas it wouldn't show if it was.
Yeah, it wouldn't show it. Yeah, that's a fair point. Yeah, you would see it on the show.
You're cutting out again, AJ.
I don't know if you can hear me right now.
Oh yeah, I can hear you. Yeah. Like, yeah. So the fact that there's been like a natural activation, depolarization is showing up. All right, I don't know.
I think we may have lost AJ there.
I think so, yeah. Have you got any questions, Jared? Like, because I think I'll see if I can post it. Like,
Yeah, R&R VAS is an interesting one. It's something that we've only seen. Well, the thing with R&R VAS is very rarely you'll see it picked up in your clinic. It's usually something that you see spontaneously, whether it be during an atrial threshold test or something like that, or someone comes into clinic presenting with it. I think they got lucky here with this one because you see the last event before it mode switches. There's an atrial sense beat, so there's an atrial ectopics coming early, which has probably caused it to mode switch. Had you have not seen that atrial ectopic, it probably would never have mode switched, and you probably would have never have seen R&R VAS. So yeah, R&R VAS isn't something that's usually stored because it's not necessarily always up at the max tracking rate like a PMT. So you get your PMT episodes, but R&R VAS is one of those things that you actually only just either patient comes in with it or you induce it in clinic. As I say, so you're very rare, or you get lucky in this situation here, where it's just happened to mode switch because of that last atrial ectopic. But yeah, it's something to keep an eye out for. But essentially, it is a bit like a PMT in that you have VA conduction. So the patient has to have VA conduction. Okay, that VA conduction obviously needs to fall in the refractory period. Now, if that atrial event falls in that refractory period in the PVAR, therefore it's not trapped. Hence why then the pacemaker tries to pace. But when it paces, the atrium's still depolarized from the previous retrograde beat. And then that atrial paced event actually doesn't capture the atrium, but it's still, the pacemaker doesn't know that. It still sets off an AV delay. And by the time you get then ventricular pacing, the retrograde limb has now recovered, so it can go back up retrogradely. And then you start this kind of essentially almost like a PMT, but it's not always at the base rate, the upper rate, sorry. And it's you do get loss of atrial capture. So essentially what's happening is the patient is just walking around with a very long first degree heart.
All right, can anyone hear me at all?
Yeah, absolutely.
Sorry, everyone, I've been dropping in and out here. One thing you mentioned, Jared, they're on new Gallant devices, the new Abbott devices, and I'm sure that Medtronic and Boston will come up with it, is a PAC response algorithm that can help prevent R&R VAS, and it will actually have an EGM trigger as well. So that's a newer algorithm that I think the manufacturers are coming up with. Did anyone hear me say that?
Yeah, we did. Yeah.
Okay, cool.
Oh, sorry, I was on mute. I was talking to myself.
All right. Okay, last one. So Elvis, you and I actually talked about this the other day. We were talking about pacing. Do you know what's happening here? You want to take a stab at it?
Hello.
Yes, sir.
Hello. Hello. Can you hear me?
Yes.
Hey, Elvis, yes, we can hear you.
Oh. I don't think there's capture. Reason because looking at the lead one, it's obvious that the V pace is not capturing the myocardium because the QRS complex, we only see the QRS complex on the V sense. So I don't think there's a capture here.
So you're right that we're not capturing the ventricle. However, this one is a weird one, and this is kind of why I said I think I've seen a couple examples of this in the clinic where people think that they're capturing, but they see a large interventricular delay where you pace, and then all of a sudden it activates. Well, not all of a sudden, it takes a long time, 352 milliseconds at this point, for something to happen in the ventricle. And what's actually occurring here is we're capturing the left atrium. So the reason why we're not seeing immediate right atrial depolarization is because they have a pretty profound interatrial delay as well. So you're actually V pacing. You can see it's pointing to the left. So it means we're pacing on the LV. The vector is on this one is 4:2. You can't actually see it, but that's actually the vector it's pacing as well as the sensing channel, the EGM channel that's on. So we're pacing at the most proximal vector. So the lead could have pulled back, or it might not have been positioned right to begin with or paced right. We're capturing something, but it's actually the left atrium. It's depolarizing to the RV or to the right atrium and the RV taking time. So a big problem with this is you'll have patients that will come in and you think that you're pacing them biventricularly, but in reality, we're just pacing them RV with a long delay. Essentially, they're using their own intrinsic conduction system if all else fails. So yeah, it's kind of a weird one. I'll go ahead and show you the whole answer here. Any questions on that at all?
That's a pretty good one, like EJ. I like that one.
Can you just repeat the answer there, mate? You said
It's
that was capturing the left atrium, was it?
Correct. So let
Yeah,
me back here. Look at it. You can actually see, but this one was pacing 4:2. So if the lead was in the heart, end of the actually capturing the left atrium. I'm not sure if you can hear me. I'm cutting out, it says, but just to keep that in mind, because if you think about it, what's happening then is if you're bi-V pacing, this one's doing a left atrial capture test, but if you're bi-V pacing, you would have pacing at the same time. We would probably capture in the ventricle, and then this left atrial capture would work its way down and effectively functionally non-capture in the through the normal conduction system. So we could be pacing this patient for 3 years thinking they're getting bi-V pacing and wondering why they're not responding. But in reality, we're just RV pacing them, which is not ideal. So always take a look. Ways you can kind of tell is having a surface is extremely helpful in this case, right? But anytime that you're doing an LV capture test and you see this really long delay between an LV pace and the sense on the RV channel, that's a red flag. Anytime that you see like an LV pace and then an atrial event occurring before or around the time of the ventricular event, that could also be an indicator that you're LV capturing and not bi-V capturing. You're left atrial capturing instead of left ventricular capture.
Okay.
Perfect. Any other questions, comments, anything?
That's great. Thanks, mate.
Oh, perfect.
Thanks, EJ.
Awesome.
Thank you.
Thank you. Thank you, everybody, for jumping on the call and spending your evening with us.
Thank you.
Have a good night, everyone.
Yeah. Thanks, Jared. Thanks, Guy. Dr. Duffy. Everyone.
Thank you, everyone.
Thank you.
Thank you very
Thank
much.
you.
Yeah, Julius.
Yeah.
Great work. Jared, AJ.
Well done,
Dr.
Dr. Dafe. Well
Yeah,
done.
well done. Thank you.
Thanks, sir.
Okay. Yeah. Let's see.